The recommendation for stress imaging. So stress imaging is one of the, has a very high negative predictive value, and a negative stress test is associated with a very low incidence of cardiac events. So the recommendation for stress imaging is before high-risk elective NCAs in patients with poor functional capacity and high likelihood of CAD or high clinical risk, and those patients who have previous history of PCI or CABG, the class 1B and the class 2AC, these are recommendations for a stress imaging before taking up the patient for a non-cardiac surgery. However, the patients belonging in the class 3 level C, they are not recommended routinely for a stress imaging before a non-cardiac surgery. So these are the frequently encountered findings which we get in our day-to-day practice while doing echo for patients who are listed for surgery. So left atrial enlargement is a very important factor, because degree of the left atrial enlargement reflects the chronic LV diastolic dysfunction, and patients with L enlargement are prone to have develop atrial fibrillation in the post-operative period. The patients with diastolic dysfunction with a normal systolic function in volume overloaded condition in tachycardia status are also prone to develop HEPF during the post-operative period if proper care is not taken. Regional wall motion abnormality is generally found in patients with ischemic heart disease. However, myocardial disease secondary to LVBB or stress cardiomyopathy should be differentiated from ischemic heart disease. Valvular regurgitation and valvular stenosis are two important findings that we often see during our echo. So patients with severe aortic stenosis, either symptomatic or asymptomatic, needs valvular intervention before a non-cardiac surgery is to reduce preoperative reduce post-operative risk. So, and patients with prosthetic valves should also be examined properly for presence of any vegetation, pannus, or proper functioning of the prosthetic valve before taking up the patient for the surgery. Patients with pericardial effusion, they should be assessed to rule out cardiac tamponade or pericardial constriction, and this should be done by keeping the Doppler, checking the tissue Doppler and also mitral inflow Doppler, and also looking at the IVC collapsibility. Pulmonary hypertension is also one of the most important finding during the preoperative echoes. The presence of moderate to severe pulmonary hypertension is commonly combined with left heart disease. Elevation of estimated pulmonary venous pressure can be a sign of decompensated heart failure. Pulmonary arterial hypertension due to congenital heart disease or idiopathic origin is at a high risk for non-cardiac surgery. So if a patient has right ventricular systolic pressure over 50, invasive hemodynamic monitoring during and after non-cardiac surgery is recommended. So these are few clips of echocardiography that we picked up during our routine checkup. So this is a patient who had come for a checkup for a spinal surgery. Female patient, we can see that the LV systolic function is good. Patient has left ventricular hypertrophy, and there is color flow turbulence in the aortic valve, and when we put the Doppler, you can see there is a severe aortic stenosis with a peak pressure gradient of 72, mean gradient of 39, and we did the Doppler velocity index, which was around 2.6, and this patient was asymptomatic, but yet one should take all precautions before taking this kind of patient for surgery. This is another patient of ischemic heart disease. This patient had a PTCA, and you can see there is reduced function of the basal septum, and we did this patient, we did the ejection fraction from the biplane method, and it was around 42%, and we also did the strain imaging, which was average around 13, and we did check the diastolic function of the patient, and we can see that there is grade 2 to grade 3 diastolic dysfunction with the E by A ratio of 2.3 and the E by E prime ratio of around 17. So this is another patient that of hypertrophic cardiomyopathy with typical mid-septal bulge and apical ballooning, and So to conclude, trans-thoracic echocardiography is an easily available, reproducible, cost-effective tool for preoperative cardiac risk assessment of patients awaiting non-cardiac surgery. However, although very informative in terms of prognostication, it should be emphasized that other investigations are also necessary for a complete assessment of a patient in question. It should also be emphasized in current guidelines, routine preoperative cardiac evaluation by echo is not recommended. Thank you.